Thank you. I do receive research grant support from Alcon, but there's no relevance on this presentation. And this is a topic which I know Professor Tithial and the team and all of the people sitting here have worked, original work, and suggested so many innovations to us. So I'm really fortunate to be speaking here in front of them. I acknowledge the contribution of Dr. Osher here, from whom I've learned a lot. And there are a few pearls, and you can go through these pearls, but all of these little details, it is the details, and if you pay attention to all these little tricks and details, you will be fine at the end of the day, and your heart will not come to your mouths. So, having done that, first is to avoid rapid buildup of hydraulic pressure between the posterior capsule and intraocular lens. Then, therefore, the subcapsular hydrodissection, or also known as the corticocleaving hydrodissection, is out of question. So, do not do that. So, what do you do that? Because you need to create a mechanical cushion effect. So, the wisdom over the years was to create a conventional hydrodelineation where you penetrate the lens substance from the anterior surface from the rexis side and penetrate and inject and create a mechanical cushion. It works very well most of the time. But sometimes, because it really lacks precision, it can go inadvertently into a wrong place, as this animation illustrates. I'm going inside, but at times, if you inject very forcefully, particularly, it can go to subcapsular, and it's the very thing that you want to avoid can happen. So, with the help of our team, we taught this technique, which we presented in 2004, worked very well at the time, and it's still working well, where you create a space in the center before you do any hydro procedure, and then titrate the width of the cushion that you want to create, and therefore penetrate with the right angle cannula into the appropriate depth of the wall of the trench and generate mechanical cushion effect. As this video illustrates, you can have a thin epinucleus or a thick, depending upon the depth that you penetrate. In a typical classical postupellar, it's not difficult, and with one injection you can create, but sometimes you have to go to the other side and so on. And third is any time of the procedure, right from the beginning, before making an incision, do not make a main incision first. Make a side pore, inject OVD, and then so that there is no forward bulge. So every step of the procedure, including the incision making, you need to be careful. And a classical teaching over the years is to inject OVD, and I would suggest dispersive OVD before you retract the instrument, and use a bimanual technique. Even if you are using a coaxial as a rule, I would recommend bimanual, although the coaxial in the expert's hand will work very well, but bimanual will maintain the contours, and once again, before you swap, inject dispersive viscoelastic and perform that removal very safely. Now, notice the low parameter. This is an old one which shows the irrigation bottle height, but as low as you're comfortable that you want to do, and low flow rate matching that low IOP. Now, this is very important, and we were doing it, and we are doing it, but there was no understanding why we were doing it, and what Osher has described is a derouting or whatever, but essentially you are creating a communication between the front of the epinucleus plate and in the behind. So you detach the epinucleus only partly, do not bring it to the center, and so what has happened is that you're creating a fluid balancing going to the anterior to the posterior, and therefore there won't be any, the risk of the rupture would be reduced. And we find, like Professor Tithial, flex technique has an advantage. We described femtodelineation in 2015, and Professor Tithial group also described similar, or not similar, but different technique using flex. And whatever technique you find, but flex in general helps us. And somebody showed us how this femtodelineation works. You're creating a cushion after cushion and come to the very last epinucleus at the very end. And this is how it would look. You create a kind of a chop in a central central delineated nucleus, and you can shell it out with the chopper and present it to the phaco tip, which remains in the center of the globe, and you can remove it very effectively, that sort of thing there. And then finally, you need to have that communication established between the posterior and anterior compartments for the fluid balancing. And that's the next step you would be able to see, I hope. But present it, all this is so easy because the laser cuts very vertically and smooth cut. It's very easy to insert a chopper or a device where you can present it there. And now I'm creating a space between these, detaching as much as you can. Obviously, you will not be able to do it subincisional, but now you can have an option. You can do a subcapsular dehydration in the subincisional area also with the 90-degree bent cannula, or you can shell it out with the chopper as you did it in the other part. So that doesn't matter what you do. But bimanual, if it is not a very thick epinucleus, also works very well, and you can clean that up to your satisfaction by swapping the instrument, and most of the time you are okay. Now, implantation is something which is nothing unusual if the rupture, the posterior capsule is intact, and you have your, typically it will be a toric lens, or a patient wants the multifocal or that sort of thing. So it's always a deadly combination, and you do not promise that lens up front, always give an option. So we found, we reported 36% incidence way back in 1999. And then we gradually worked out, and with the delineation 3.8% when we reported in 2015, probably it is little less, but it is still not 0%. This is a 49-year-old male, bilateral pre-existing defect. Left eye, white cataract, other one you could see the defect. So we decided to do the first eye with a clearer lens in front with the femto delineation, and we found, and you can recognize the posterior capsule pre-existing defect there. And so we need to do the same principle, but the aim here is to prevent vitreous prolapse into the anterior chamber area, and the same principle, but lower IOP and lower flow rate. The flow rate would be 16 or 18 or 20 depending upon the comfort, but as low as you're comfortable, and IOP very low. We don't want too much pressure there, although you want to prevent surge or a forward bulge. So on one hand, you want the pressure sitting on it, but have a balance of it. And typically with these flex techniques, it is not that difficult to present the material, and the same principle. And now I'm using a 3-piece IOL here, haptics in the sulcus, just behind the iris, in front of the anterior capsule. And then I would like to capture this, and I have an option, anterior capsular axis, which is good with the lens X, and also posterior, the tear. This tear is very strong because it resisted all the maneuvers and until the surgery. So I believe that the zonules are preventing it to go over on the other side of the posterior capsule. So I'm capturing through both anterior capsule and that tear which is in the posterior capsule. Always make sure that there is no vitreous at the end. I had the retractor out, so I had to use it and justify that. But otherwise, the IOL is captured through both the axes, and this is how it looked down the line. Always monitor with retinal colleagues and document as much as you can. But this is the other eye. Now we are confident to do the other eye, so we did a flex again, and that's a great thing in a wide cataract. Inside-out technique here. Even if the lens is dense, you try, don't lose your heart. Whatever you can, most of the time you will be able to do it. Obviously, if it is very hard, you won't succeed. But a thin epinucleus plate is enough, and then you do all the manual tricks that you learned, remove with the bimanual, and once again, this lens is removed, no drop. But because I suspected a vitreous loss, I'm doing a vitrectomy, and you have an option of doing limbal vitrectomy, both irrigation and vitrector in the front, and also other option, and I find this is useful, irrigation still in the front, but one port vitrectomy. And our aim is to do a vitrectomy not only in the center portion of the eye, but also behind the area of the optic, so that the IOL is supported very symmetrically. And once again, the procedure is repeated, where we put the lens haptic in the ciliary sulcus and capture through the tear as well as anterior capsule. Because these tears, because they are present for some time, they are fairly strong, so you don't need to worry about it. So I'm just trying to show that the optic is behind the tear as well as the anterior capsule, and then always check it as I showed you in the early part, and make sure. Now, this is the most important part. Always talk to the patient. Patient is always nice and he understands, but the relatives don't understand. Their spouses, their parents, because they are young people. They are worried about the young persons for obvious reasons. So tell them, bring them back again, the whole family. We have a rule that we do not, when they come for the preoperative workup, which is separate from the OPD, separate time slot, they come with the family and we hammer them, the thing. But remember this, and I keep showing every time this one. We were so happy, all the nurses packed up their trolley, and this is what happened. So posterior polar is not over until it's really over. So thank you so very much for patient hearing. Thank you for readjusting. Thank you.
Over to the next presentation, the role of imaging in cataract surgery. As sir sets up, sir, what's your take on doing hydrodissection in cases in which in OCT you don't feel it's high risk?
Sorry, sir, where you do?
What's your take on doing hydrodissection in a subset of cases of posterior polar in which you feel like
you can do it.
Posterior capsule is not that involved?
Yeah, but I'm a coward. I'm very timid. Once I know it's posterior polar, and I know in my heart that I'm not going to rupture because there are observers coming to see, but I will follow the principle. It's a discipline. I mean, I'm sure you can do it, and you can make a 6 or a 4 sometimes, but not everybody's Shivam Dubey. Okay.
The FEM2. Myself is a very poor. I have no Sukhaya or Mirage, but I have the Centurion gold machines. How can I manage the PC? It is mandatory to have the FEM2 to tackle the only 3%. You have told it 3%. 3%. Now, yesterday I have.
But you need a machine with a retractor capability, which you all have. All the machines have now. So
another, just one question: what is the cortical separation, mechanical cortical separation in PP cataract management?
Mechanical separation.
Mechanical cortical separation. Yep.
I've not done it, but if you are doing it, carry on. Thank you.
Thank you, Abhay, for a wonderful presentation. As usual, he's been a teacher to all of us across the world.